There are about 60,000 lower extremity amputations each year in the United States in patients with diabetes, most of which could be prevented by a comprehensive treatment and prevention program. Here at the Gillis W. Long Hansen's Disease Center in Carville, Louisiana, we have used the total contact cast in the treatment of plantar ulcers for over 20 years in patients with Hansen's disease, diabetes, and a variety of other diseases that result in insensitivity of the foot. When used as a part of a team approach with a clear understanding of the indications and contraindications, and with proper application of the cast, our healing rate of plantar ulcers has been over 90%. The following video presentation describes the basic techniques of cast application used at Carville. It is intended to assist you in developing the necessary skills to apply a total contact cast.
The total contact cast is indicated for Wagner grade 1 and 2 plantar ulcerations, neuropathic fractures, and post-operative immobilization. Casts are contraindicated in the presence of acute infection, narrow, deep wounds, active dermatitis, claustrophobia, and excessive swelling. The materials used in fabricating a total contact cast include sterilized X-ray film and a felt tip or China marking pen, cotton cast padding, cotton stockinette pre-sewed on one end, one-8 inch felt strip, and pre-cut felt relief pads, 3/8 inch self-adhesive polyurethane foam, 2 rolls of 4-inch gypsona or similar high-quality plaster, 2 rolls of 4-inch standard fast-setting plaster, 2 sets of 5-inch plaster splints, 5 layers each, a 1/4 inch oval-shaped piece of plywood and rubber walking heel, 1 roll of 4-inch fiberglass casting tape, and a supply of warm water. The wound is traced using clear X-ray film and a felt tip pen. Tracings provide a reliable record of wound healing. A light, dry, or saline moistened dressing is taped to the skin after the wound has been debrided and cleaned. Cotton cast padding is placed between the toes, and in this case over the wound dressing, to prevent maceration. The leg is then covered with a snug-fitting cotton stockinette. The pre-cut 1/8 inch felt pads are placed over the prominent bony areas, including the malleoli, the navicular bone, and the tibial crest. It's important that the assistant hold the foot in a neutral position throughout the fabrication process. The adhesive-backed foam is next fit over the toes and the lesion area. The toes are covered in the cast to prevent direct injury or entry of foreign objects. Cotton cast padding is layered lightly around the proximal leg. Over the pretibial area and the heel and dorsum of the foot. This additional padding provides protection from secondary lesions due to friction within the cast. Two to three layers of 4-inch gypsona plaster are then wrapped over the lower leg and foot, starting just below the fibula head. The first roll usually covers to the ankle area. And then a second roll of the plaster is needed to cover the foot. The plaster is rubbed continually until it sets hard. This provides a smooth molding around the contours of the leg and foot. Next, we apply 2 sets of plaster splints to reinforce the cast. The proximal edge of the stockinette is rolled and trimmed, and an additional roll of 4-inch plaster provides a smooth outer layer. Pieces of plaster are now used to level the bottom of the cast before applying the plywood board and rubber walker. The board will add strength to the walking surface. The rubber walker is placed level, approximately 40% of the distance from the heel to toe, and then wrapped in place with plaster. A final layer of fiberglass casting material is applied over the ankle and foot, providing additional reinforcement. An ACE wrap is then applied to smooth out the fiberglass layer. The fiberglass dries in several minutes and the ACE wrap is removed. The total contact cast is completed and it may be checked for snug fitting. Casts are changed if the patient reports any discomfort, loosening or damage to the cast, any fever, lumps, or swelling in the groin, which are signs of infection, any odor or staining from wound drainage. The cast should be changed 1 week after the first cast and afterwards every 1 to 2 weeks until the ulcer is fully closed. You've been watching the Total Contact Cast, the Carville approach. This program was produced by the Rehabilitation Branch through the television facilities of the Training and Education Branch at the Gillis W. Long Hansen's Disease Center, Carville, Louisiana. Fabrication of the walking splint. At Carville, the walking splint has been shown to be an acceptable alternative to the total contact cast in the treatment of plantar ulceration. The splint may even be preferred to casting in the presence of dermatitis, infection, non-plantar lesions, or poor circulation. The splint may be used on patients fearful of confinement or who have had secondary injury from previous casting. The walking splint is also appealing to clinicians who are inexperienced in casting techniques.
The materials used in fabrication of a walking splint include 3/8 inch adhesive back sifoam, a cotton sock or stockinette, pieces of 1/8 inch felt, cotton cast padding, four-inch plaster bandage, five-layer sets of 5-inch wide plaster splints, 4-inch wide rolls of fiberglass taping, a rubber walking heel, and an elastic bandage. The wound is covered with a dressing appropriate for the amount of drainage. The patient is positioned prone with the knees bent to 90 degrees flexion, relaxing the position of the ankle during fabrication. A cotton sock is pulled over the foot and leg, avoiding wrinkles. The sock will provide a protective layer between the foot and the splint. Layers of cotton cast padding are wrapped smoothly over the sock layer. Cotton is preferred to synthetic padding because it conforms better to the leg. A piece of foam is cut into an oval shape and after beveling the edges is fit over the heel. Padding will provide protection from injury when the splinted foot is rested on the heel. Pre-cut felt pads are taped over the lateral malleolus, medial malleolus, and prominence of the navicular bone. When treating forefoot ulcerations, foam is cut and shaped to cover the ulcer area and extend out beyond the toes. When ulcers are located at the midfoot or heel, the foam is cut about 2 to 3 times the size of the ulcer, edges trimmed, and placed directly over the lesion area. Felt or foam may also be placed under the toes. The placement of foam padding over the lesion provides local relief in the splint during fabrication. Two sets of plaster splinting, 5 layers thick, are cut to the length of the leg. After soaking in water, they are applied and worked well over the ankle, foot, and lower leg. The ankle edges are cut and overlap smoothly. Excess plaster along the edges is trimmed. A third set of plaster splinting is applied medium laterally over the leg to reinforce the ankle. Layers of fiberglass taping are used to strengthen the splint. The tape is sticky and gloves are put on to protect the hands. The fiberglass is wet and laid over the splint, attempting to cover the entire surface, especially the medial and lateral edges. An ace wrap is used to smooth and adhere the tape to the plaster. The fiberglass sets up quickly and the ace is unwrapped. The hollow area in the arch is filled in with 4-inch plaster. A walking piece is fit to the splint. The middle of the heel is placed just ahead of the tibia, and care is taken to align it horizontally as viewed from the front and the side. A second roll of fiberglass is used to fix the walking piece and reinforce the weakest area of the splint, the ankle. An ace wrap is again used to smooth the fiberglass and hold it snugly in place until set. After setting, the ace is unwrapped. A standard cast saw is used to trim and remove the excess fiberglass around the front of the ankle. The patient is assisted in turning onto their back, and the cotton padding is cut down the front to allow removal of the splint. The leg is eased out of the splint by asking the patient to first pull up their toes. The cotton lining is glued to the sides of the device to improve its appearance and prevent unraveling. The finished splint is held to the leg by a snug wrapping with an ace bandage.
The patient is instructed to walk with partial weight bearing, using crutches or a walker to provide additional protection to the foot. The patient is informed that they have been fit with a walking splint to help heal their ulcer. The splint, however, will only be effective if it is fitting comfortably, undamaged, and worn whenever the foot touches the ground. A poor fitting splint can result in further injury to their foot. Therefore, the patient is advised of the following: not to bear weight on the splint for the first 24 hours. Early weight bearing can damage or deform the device. Remove the device twice a day during the first 48 hours to check the skin for fitting problems. After this initial period, the splint may be removed for daily dressing changes or even less frequently if drainage is minimal. Call their clinician if any pain, redness, fever, swelling, or new injury to the skin develops. And the patient is usually advised to wear the splint at night. A sock should be worn on the opposite foot to protect it from splint rubs during sleeping. You've been watching Fabrication of the Walking Splint. This program was developed by the Physical Therapy Department and produced through the Training and Education Branch.
There are 70,000 lower extremity amputations each year in the United States in patients with diabetes. What can you do to help reduce that number? While it is important to develop a comprehensive insensitive foot treatment program, and this is what most medical professionals are interested in, what is more important if you're going to prevent deformity, disability, and ultimately amputation is to see the patient before a plantar ulcer or Charcot fracture develops. Therefore, prevention must be the foundation of any program involved with managing the insensitive foot, whether the etiology is diabetes, Hansen's disease, or any other diseases that result in insensitivity. At the Gillis W. Long Hansen's Disease Center in Carville, Louisiana in the mid-1980s, we developed a standardized, systematic screening examination of the foot that enables us to identify those patients with a high risk of developing foot problems. The Carville foot screen will allow you to focus your energy where it belongs, on preventing deformity and disability, and not just on treating large numbers of patients referred for plantar ulcer care. As the team member who performs the foot screen, whatever your profession may be, you have a crucial role to play in preventing foot problems. The following video presentation is intended to assist you in developing the necessary skills to perform an accurate foot screening exam.
Foot screening, the Carville approach, will provide you with the information needed to make an initial diagnosis of a foot problem, develop a treatment plan, and schedule follow-up examinations at appropriate intervals. Foot screening will enable you to determine the necessity of doing a more detailed examination or referring the patient to a specialist. Foot screening will enable you to document the level of foot deformity and disability in a patient. And when used as a baseline, the foot screen will enable you to compare the initial foot screen to future examinations to determine if there is improvement or worsening of the patient's condition. In this program, we'll use the diabetic foot screen form developed at Carville as our guide. The form has 4 components. The first section is for basic patient information. The second component consists of 5 questions to be asked of the patient during the foot screen. The third section of the form is a graphic record to be completed during an actual sensory exam of the patient's feet. The last component deals with selection of a risk category for the patient following the complete foot screen. Now, we will work our way through the foot screen form as we view an actual foot screen session.
It's nice to see you again, Mrs. Carbon. How have you been since we last saw you?
Fine.
That's really great. We're getting ready today to do a foot screen on you. We have to do it annually, and today's the day for you. Has there been any change in your feet since your last evaluation, weakness or loss of feeling?
No.
The purpose of this question is to determine from the patient if he or she has perceived a change in the strength or sensation of their feet. Any change is significant in a foot screen. For example, if the patient perceives a change for the worse, this could be a sign of worsening of the neuropathy. On a first visit, NA is checked unless the patient has noticed a change in strength or sensation within the past year. If that is the case, check yes.
Have you ever had a foot ulcer?
Yes, I have.
And what side?
On the left foot.
Left foot.
The purpose of this question is to determine if the patient has now or has ever had an ulcer on the foot. Once a patient has ulcerated, they are always at an increased risk of developing recurrent ulceration, progressive deformity, and ultimately amputation of the foot. At this point, question number 3 is, does the foot have an abnormal shape? Obviously, this is determined by inspecting the general shape of the patient's foot and comparing it to the examiner's own experience of what a normal foot looks like. Conditions to consider include foot drop, eversion or inversion deformity, partial or complete amputations of the foot or toes, clawed toes, bunions, and especially a Charcot foot. A Charcot foot is a foot which is moderately to severely deformed as a result of insensitivity and repeated injury. Fractures in an insensitive foot frequently fail to heal properly and can progress to the so-called boat-shaped foot or Charcot foot. These feet are at extreme risk of amputation and require immediate expert care.
The next thing I'd like to do is to check to see if you have any weakness in your feet or your ankles. So I'm going to have you step on the floor and put weight first on your heels and walk, and then on the balls of your feet and walk. Mrs. Carbon, normally we ask patients not to go barefoot on the floor, but for this test we want you to walk on the bare floor. So I want you to take a few steps on your heels. That's fine. Now on the balls of your feet. That's fine.
Unless the patient has an open ulcer or infection of the foot, a rough estimate of strength can be made by asking the patient to walk alternately on their heels and then on their toes.
I noticed that your toenails are short. They're kind of thick. Have you ever had any ingrown toenails?
No, I haven't.
If severe nail problems are present, or if there is uncertainty about the vascular status of the toes, a referral to a foot care specialist may be indicated. The 5 questions can be answered in the yes or no blank with an R, L, or B to indicate a positive or negative finding in the right, left, or both feet. Our 5-question component is now complete. In the next section of the foot screen form, the examiner performs a sensory exam of the foot using a nylon filament and records the findings in the circles on the foot drawings. The sensory testing device is a nylon filament mounted on a holder that has been standardized to deliver a 10-gram force when properly applied. Our research has shown that a patient who can feel the 10-gram filament in the selected sites will not develop ulcers. The filament should be applied perpendicular to the skin surface. You should apply sufficient force to cause the filament to bend, but don't allow the filament to slide across the skin or make repetitive contact at a test site. The approach, skin contact, and departure of the filament should be approximately 1.5 seconds duration. There are 10 places on each foot that are routinely tested. If the patient can feel the filament, put a plus in the appropriate circle. If they cannot feel it, put a minus or negative. The quieter and more relaxed the setting, the more objective the test will be. If at all possible, the sensory test should be done in a room where the patient can lie down.
Mrs. Carbon, I'm going to touch you on your feet now with this little filament, and if you feel me touch you, just say yes.
Yes.
All right, now I want you to close your eyes and just respond yes if you feel me.
Yes. 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 Yes.
The drawings are marked according to your findings.
Okay, now just respond yes if you feel me touch you.
Yes. 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 Yes.
Again, your findings are recorded. Next, examine the feet closely and then record the problems found by diagramming and labeling on the drawings. If there are calluses, pre-ulcerative lesions, or open ulcers, draw them in as accurately as possible. Then draw in and label areas that are significantly red, warm, dry, or macerated. Suggested patterns and labels to denote lesions and conditions are given on the footscreen form. Next, you'll notice a block titled Vascular on the form. This part of the screen is optional and depends on what is available in your clinic. Vascular studies are an important part of foot evaluations in patients with diabetes. The last and key component of the footscreen form is the risk category. The higher the risk category, the higher the risk a patient has of recurrent foot ulceration, progressive deformity, and ultimately amputation of the foot. Our footscreen patient is placed in risk category number 3, since she has a history of plantar ulceration. At this point, let's briefly discuss the guidelines for each risk category. Category 0. This is a patient that has essentially no risk of developing foot complications as a result of their disease. They do not need special footwear. Category 1. This patient has lost protective sensation. They cannot feel the 10-gram monofilament. The patients in this and the following 2 categories should never walk barefoot because they do not have enough sensation to prevent injuring themselves. Category 1 patients need to pay special attention to the fit and style of their shoes, but do not need custom shoes. These patients do quite well in a jogging shoe or a well-fitting street shoe. They should avoid pointed-toed shoes or high heels. Category 2. This patient, in addition to the loss of protective sensation, also has significant deformity of the foot, but has not progressed to the point of ulceration. They need to pay special attention to fit and style of shoes and may need extra depth shoes with molded inserts to accommodate the deformity of their feet. Category 3. Patients with a history of plantar ulceration may need extra depth shoes with soft molded inserts or even custom shoes to manage their foot problems once their ulcer is healed.
Okay, Mrs. Carbon, that does it for today. We'll check you again in a year since you have the history of the plantar ulcer. And you should have your feet looked at every 3 months, and then the foot screen just as we completed it at least every year.
Okay.
So you take good care of those feet.
You've been watching Foot Screening the Carville approach.
I think almost everybody appreciates the joy of sensation in the hand. We love to hold hands with each other. We like to handle textures and objects and feel what they mean to us. But in this country, at least, I think a lot of people miss the joy that can come from sensation in the foot. To me, there's nothing so refreshing in the morning when the dew is on the grass to come out and feel the sensation of walking barefoot. But you know, sensations in the foot are not just for pleasure and for ecstasy. They are for protection as well. When a foot becomes insensitive from any cause, it loses the ability to protect itself. It's easy to understand that a foot needs sensation to know when there's danger from sharp stones or broken glass on the floor. Most people do not realize that feet without sensation develop most of their problems not from the sharp object that they step on barefoot, but from gradual development of soreness and inflammation, which builds up slowly in a foot that's walking in an ordinary shoe. Normal people get the same kind of soreness, but they feel it long before it gets to the level of real pain. They make small changes in the way the foot comes down and takes weight so that the sore areas of the foot are relieved and other areas take the weight. It's this protective instinct that forces people to slow down or limp a little. And it's the loss of feeling in the foot that makes it dangerous for people to walk very much. Now we can help to make walking safe, even without sensation, if only we can provide shoes which will allow a really large area of the sole of the foot to share the weight. If a large area takes the weight, then no area will be subjected to really high pressure. And in the absence of high pressure, the sore areas won't develop, and it becomes safe for the foot to go on walking and walking almost indefinitely. And these feet should really last a lifetime. First, let's remember that a normal foot does a pretty good job of spreading the stress, even when it's insensitive. The sole is made up of soft, elastic, fat and fibrous tissue, and it conforms to the shape of whatever it stands on, up to a point. This is why, if we can persuade people who have lost sensation to begin taking care before they get damaged, they can get by with very slight changes in their footwear and their walking habits. We call these feet grade 1, meaning that they're insensitive, but with normal sole structure. Unfortunately, we often see patients for the first time after previous ulcers and infections have destroyed part of the soft tissue layer of the sole. Those people are much more likely to have high pressures under the parts of the foot that have only skin and scar to cover the bones and cushion these forces. These are grade 2 feet, and they need extra care to substitute for the loss of their own sole material. Still more damaged feet are called grade 3 and have suffered bone destruction. The foot is shortened and irregular in shape. The area available for weight bearing is reduced, and there may be prominent bones, resulting in much higher pressures. However, the principle is the same, whether the feet need just a little help or whether they need a lot. The principle is that they need to have the stress of weight bearing spread as widely as possible across the foot, so that no one place on the foot takes so much stress that whenever the patient goes for a walk, he's going to get sore and inflamed. So now we need to begin to discuss how we spread the stress. What are the methods by which we equalize the stress over the foot when patients go walking? I just want to clarify our use of the terms force and pressure. Pressure is force divided by the area through which it acts. So we are concerned with reducing pressure. We can reduce it either by reducing the force or by increasing the area. Now, in the case of shoes, the force is the body weight. The body weight has to reach the ground somehow, and it can only reach the ground through the feet and through the shoes. And therefore, we're not going to be able to change the weight. The weight comes down through 2 feet, and each of them may have perhaps 20 square inches. And you see the force is spread out through 40 square inches, and these little units of pressure here show that it's very nicely spread out. It may be as low as 10 pounds per square inch. But the problem is that every time a person walks, he lifts his feet alternately from the ground. And therefore, at a certain moment in his stride, he's standing on only one foot. But that foot now has to take the force from both the feet that both the feet previously had. And therefore, there are twice as many units of pressure. And this foot is taking much higher pressure. But that isn't where it stops. Every time he goes forward to take the next step, he lifts his heel off the ground. And now only half of the foot is taking the weight. And now you've got half a foot with the same force as previously came down through 2 whole feet. And now your pressure is very high indeed. That's when the trouble starts. Now, we've got to try to reduce the pressure. We can't reduce the body weight, and therefore we somehow have to find a way, when one foot is off the ground, to increase the area again so that the amount of pressure per unit area is reduced, or at least kept down to a minimum. I want to talk about 3 ways of spreading the stress by modification of footwear. The first is by softness, the second is by molding, and the third is by rocking. If a person walks barefoot on a soft surface, like a thick pile carpet, a grass lawn, or soft sand, every time he puts his foot to the ground, the step is modified 2 different ways. The soft surface spreads the stress in space and in time. If you could always provide soft surfaces for your patients to walk on, no other precautions would be needed. Soft substances don't reduce the force, but by conforming to the shape of the foot, they increase the area that shares the force. Also, by reducing the speed of the foot's impact with the ground, they spread the force in time. But a really soft surface is more tiring to walk on. Much of the energy of walking is absorbed by the soft substance. In an insensitive foot, it's these prominent bony areas that take the brunt of the pressure of walking, and that's where we get most problems. Now, if you have a relatively thin piece of soft material, it does indeed spread the area. As this prominent area sinks in, the part of the foot that takes the pressure is perhaps doubled in area. But still, the part under the arch is not even touching the sole. If you can get a really thick piece of soft material like this, now when you take weight on it, the foot sinks right in, and the arch is taking pressure as well as every other part of the sole of the foot. And this looks good. But even so, this isn't absolutely perfect, because you'll see that the prominent part of the foot has compressed the soft material down to a half its thickness, whereas the part under the arch is still almost full thickness, and it takes more pressure to compress the foam all the way than just part of the way. Nevertheless, thick, soft foam is excellent. It does spread the stress. But there's a problem. And the problem is that in order for the whole foot to take the stress, you have to sink into the foam. You've got to go into it quite a long way and come up again, and you go in and you come up. And if you're inside a shoe, this means that the foot is moving up and down inside the shoe. We use thick, soft insoles primarily in open sandals, like these, which are my own favorite Indian sandals. And the sandal straps move with the compression of the insole. And so no rubbing occurs while the foot is molding the insole to its own shape at every step. The development of closed-cell foam materials, such as microcellular rubber and closed-cell polyethylene foams, has tremendously improved their cushioning capability. The big advantage of a closed-cell foam over an open-cell foam is that the air which is in the little bubbles in the foam is trapped there and can't escape under pressure. It stays in the foam and is compressed. Thus, in walking on closed-cell foam, one is really walking on air. And air is highly elastic and very compressible. For this reason, the same thickness of closed-cell foam will provide a better pad for the foot. Even thinner insoles of closed-cell foam, though they don't provide widespread conformity, do provide cushioning that's often adequate for minor pressure problems. Because of the problems created by the need for a thick layer of soft material inside a shoe, we need to look at another way to spread stress. Since the soft material is effective mainly because it molds itself to the shape of the foot when it's compressed, why don't we try an insole which is already pre-molded and therefore doesn't need to be compressed? First, think of molding as a molded hard surface. You can take a hard material and shape that hard material to fit the foot exactly. As soon as the foot contacts the insole, it stops, because every part of the sole is at once in contact with every part of the insole, and the hard materials don't change shape. It's the pre-molding which causes the pressures to be decreased by increasing the surface contact area. More of the bottom of the foot shares the weight. By molding, the highest pressures can be reduced 5 or 6 times. Molded insoles are more efficient in spreading stress than unmolded soft materials. The problem with using hard materials in a molded sandal is that they have to fit perfectly. There's no room for error or guesswork here. If the rigid sole doesn't fit perfectly, you're in deep trouble. If the hard molding is on the inside of a sandal, for example, the straps must hold the foot securely in position. I used to have problems with this when I was in India. I got my skilled carpenters over there to make molded insoles of wood, wooden clogs for each one of my patients, and they would do really a good job of molding these insoles, and it would be a perfect fit. And then we would fit straps to the insole, and the patients would take them home. Unfortunately, the straps that we used in those days were kind of loose and not very durable, and after a while, the patients would sometimes come back to us, and the clog would have shifted in its alignment. And it would be a little bit like this. If this blue thing is the clog, then this bump on the clog that was supposed to fit in the hollow of the foot would have shifted back a little. And now the bump on the clog would be against the bump on the foot. And we had the most terrible ulcerations because the insole was hard. So when you use a hard surface that's well molded, you've got to make it stay in position. Of course, if you're using an Oxford shoe or any kind of complete shoe, you can be pretty sure that the patient's foot is going to stay in position on the insole. It isn't going to move around. What we do in practice is to combine the virtues of molding and of softness by covering a firm mold, such as this one of cork dust, with a thin layer of soft material, like this foam. This 1/8 of an inch of foam compensates for possible small errors in the molding or errors in the placement of the foot on the insole, and makes it safe. Or we may use a firm mold like this as the basis for the molding, and then cover that with a thin layer of soft material. The advantage of these materials, such as Plasterzote and Pelite and Aliplast, is that they can be directly molded, directly heel molded onto the patient's foot or onto a plaster model of the foot, thus making absolutely certain that the mold is accurate. Now that we have materials that can be molded directly on the foot or on a plaster model of the foot, there's no excuse to prescribe or use any device that is bought off the shelf and placed in the shoe by guesswork. We should not prescribe mass-produced arch supports or metatarsal cookies for insensitive feet. Now we come to a very difficult problem. Even though you may have a well-molded insole, at every step, that patient is going to lift his heel off the ground. At that moment, the other foot is off the ground, swinging forward for the next step. This means that at a critical time in each step, all the pressure is being localized to the forefoot. Most of the pressure problems which lead to injury from walking are found under the toes and under the metatarsal heads. If I measure the pressure under the foot while just standing, I may get a very evenly distributed pressure of 5 to 10 pounds per square inch. But when the heel leaves the ground, all of the molding around the heel and the arch and the midfoot does no good whatever, because the forefoot is taking all the weight. The metatarsal head is here, and the ulcer is to be found here, plantar but distal. This is when the heel is off the ground. Now we have to think about the problem of spreading the stress on the underside of the surface of the foot at that particular moment in gait, when the heel is off the ground. If I use this piece of wood in the shape of a foot and assume that it's like a shoe, when I lift the heel, then all of the weight of the patient is coming on the toe end of this board, and it's concentrated. Now if I take this elevation here and use it as a rocker, now I can make my shoe into a kind of a seesaw, and as I lift the heel, the weight of the shoe and the weight of the person remains in the center of the foot. And now I can come down on the rocker, I can level off on the rocker, I can lift my heel, and I'm still on the rocker, and I can take off. On top of my rigid rocker, I can have a soft insole to help spread the stress within the shoe, and it's still a rocker, or I can have a molded insole, and that can go on the rigid sole, and it can rock in this way. The rocker allows me to spread the stress even when the heel is off the ground, and you can make it into the shape of a shoe like this, and here is a rocker. Or you can make a complete shoe around it like this. But I must stress one very important point. If it is to be a rocker principle, the shoe must not be able to bend. I cannot bend this shoe. There's no flexibility in the sole. This is a rocker. A lot of doctors prescribe metatarsal bars or anterior heels as a method of spreading the stress inside a shoe. And we've done this too. But I want to say loudly and clearly that a metatarsal bar is not a rocker. The principle is completely different. A metatarsal bar is most effective if it's placed on the underside of a flexible sole. And as the patient takes weight, the shoe bends and changes its shape in front of and behind the metatarsal bar. Even when the sole is made of firm leather and does not easily bend, the metatarsal bar will gradually change the shape of the sole until leather is touching the ground in front of the bar. As the sole bends around the metatarsal bar, it presses the insole against the foot. This characteristic makes the bar another form of molding. It molds the sole behind the metatarsal heads to relieve the metatarsal pressure. With a rigid sole, the sole doesn't bend, it just tilts on its central rocker. The most serious forefoot pressure problems should be addressed with the rocker. These people should never be allowed to take weight only on their forefoot. Placement of this rocker is very important. If the rocker is placed too far forward, as on this Japanese sandal, the heel will lift inside the shoe. If the rocker is positioned too far towards the heel, the person will rock over even while standing. Also, the shoe will rock forward during the gait cycle when the opposite foot is not ready to take weight, creating a great deal of instability. If a line is drawn directly down from the metatarsal heads, the rocker can be placed here or slightly behind the point where this line meets the bottom of the sole. In this location, as the heel lifts, the weight is transferred to the forefoot, and the shoe also lifts at the heel. When you apply a rocker to the underside of a rigid sole shoe, you have to design it so that the toe of the shoe doesn't touch the ground, doesn't take any weight. Now, this is a good rocker design, and you see a person can lift the heel and walk over, and then they take off for the next step. If a person really wants to take long strides or walk very fast, or if the foot is a very long foot, then in order to keep the toe clear of the ground, you have to have a higher rocker. And here we have a higher rocker, and now a person can lift the heel higher. But that's unfortunate, because the higher you are from the ground, the more you're in danger of tipping over, and the patient may have problems spraining their ankle, perhaps. What we do in practice is to turn the toe of the shoe up a little bit. As we take the model, we have the toes a little bit turned up, and then when we put a molded insole or a soft insole on top of the rigid rocker, the patient is better able to lift his heel without taking weight on the forefoot. But I believe that this is so important that one has got to either be prepared to have the rocker further forward and not so high in order for it to be acceptable to the patient. Here, for example, is a nice little rocker shoe, which is the toe is turned up a little, and as the person lifts the heel, they can get quite a good gait without actually taking weight on the end of the shoe. Before turning up the toe of the shoe, be sure the person who is getting to wear the shoe has enough motion in his toes to allow this modification. Whenever we advise a high rocker, we're introducing some degree of instability. We are lifting the foot high enough off the ground that it can tilt over sideways on rough ground and produce damage at the ankle. I think that this danger is serious enough to be worth prescribing a boot rather than a simple shoe. This boot has a high quarter going above the ankle, and it helps to prevent the danger of turning over sideways. The other kind of instability that we introduce is a fore and aft instability. And this is something that the patient is more conscious of than he is of the lateral instability, because he feels as if he's tripping over forwards. As he lifts his heel, there's nothing to take his weight under the forefoot. And he's kind of unhappy about this. But from our point of view, it's good, because it forces him to take short steps. And when you take short steps, you even out the sequence of weight bearing, and you reduce the high pressures. And therefore, the important thing is that the patient should be warned ahead of time that this is part of the treatment. He's going to have to walk with shorter steps. And if he realizes that it's all part of the game, then he will shorten his stride, and he won't feel unstable, and he will actually wear the shoe. We have a saying at Carville that it's better to have a less than ideal shoe that is actually worn than to have a completely ideal shoe that's left in the cupboard. One modification which provides perhaps a slightly less perfect distribution of pressure, but it gives more stability and a better appearance, is the roller shoe. A rocker tilts around a single fulcrum, whereas a roller moves forward gradually. If you examine Dutch clogs or Swedish clogs, you'll see that the sole of the shoe is curved on a roller shape. And our roller shoes with a rigid sole have a similar appearance and a similar action. This is an improvement over the flexible sole, which allows pressure to remain on the metatarsal heads and toes throughout this propulsive phase of walking. A special feature of the roller shoe, just like the wooden clog, is that it must have a rigid sole. A special value of the rigid sole, in addition to its spreading of pressure, is that it prevents bending of the metatarsophalangeal joint area, the ball of the foot, in walking. This bending is productive of shear stresses, and this is particularly harmful in people who've previously had ulcers under the metatarsal heads. The rigid-soled shoe, even without a rocker, can provide some benefit, particularly when there is stress problem under the toes. When the heel is lifted during walking, the toe of the shoe is bent upwards by the ground. If the toes resist this motion by being rigid, very high pressures can result. The rigid sole can protect such digital problems. But still, a slight roller needs to be included so the shoe will tilt to prevent the patient from pulling his heel out of the back of the rigid shoe. At Carville, shoe soles are made rigid by including a steel corset stay into the sole of the shoes. First, the heel of the shoe is removed, then the stay is bent to the shape of the existing shoe sole with some extra curvature at the front to lift the toe. The stay is then glued in place, and layers of neoprene crepe soling are laminated on to construct the rocker. The final step is the addition of a hard rubber undersole to extend the sole's durability. This is a roller sandal of the type that we use for village work in India, and this was made in India. The rigidity of this roller is because of wood. We use a layer of wood in the center here. That's wood, and over the wood there is a layer of microcell rubber which cushions the insole, and underneath the wood is another thin layer of microcell rubber under the wood to give a little spring, and then there's a layer of hard vulcanized rubber to take the wear and tear, and this in India is made from the sidewalls of old automobile tires. Underneath, you'll notice that there's a hollow in the center here, which is really to accommodate the roughness and irregularity of the jungle paths and stones, so that a stone in the middle of the shoe doesn't make the patient tilt over and break his ankle. So here we have an Indian village roller sandal. Now finally, a word about the value of a soft undersole, soft material under the sole of a shoe. We've already talked about softness inside the shoe and demonstrated that it conforms to the shape of the foot. But softness also has a value underneath the shoe. If I hit this hard sole with my fist, it's quite uncomfortable. It's a little painful. But if I put this soft material underneath that hard sole and hit it in the same way, it feels completely different. Not because the material has conformed to my fist, which it hasn't, but simply because as my fist comes down, there is a slower deceleration. It doesn't suddenly come to a stop. It has spread the stress in time rather than in space. And this is really valuable, and one can sometimes get relief from localized sudden stress by having a soft undersole under one's shoe. When you really study a shoe, you find that you can change and adapt almost any part of it to help in this overriding objective of spreading the stress. It's also important to remember that the force of walking is reduced if the person just takes shorter steps and walks more slowly. On some people, even more extreme measures may be needed to protect their feet. This method is inexpensive too. Let's just review. Minor pressure problems under a foot which has never previously been ulcerated or damaged can be addressed with a thin layer of flat, nylon-covered foam material, such as Spenco or PPT. If additional protection is needed, materials which are more firm can be molded to the shape of the bottom of the foot. Shoes which have extra depth inside can be obtained to accommodate thicker or more deeply molded insoles. Further protection can be included for the toes and metatarsal heads by making the sole of the shoe rigid. Including a rocker gives the ultimate forefoot protection while walking.
Pain and his reaction to it will protect this man's normal feet from serious injury while walking on jagged shells. But in Hansen's disease or diabetes, the ability to feel such pain in your feet may be lost. Your feet self-inspection. A patient guide to the proper techniques of daily foot, shoe, and sock inspection. Injury protection in the absence of a pain warning system.
And check your feet all the time. That's one thing that really I noticed that helped me more than anything else, is to check your feet at night or check your feet at noon when you change your shoes or take your shoes off when you come home. Or if you work and you come home at dinner time, take your shoes off, rest your feet, and check your feet, because you might have little red spots where you get pressure. And before you know it, you have a blister. Before you know it, you have an ulcer if you don't check them. But check them good.
Now, with the guidance of a therapist, we would like to show you how to carefully inspect your feet, your socks, and your shoes.
Inspect your feet at least once a day. The best time to do this is before going to bed. After removing your shoes, inspect your socks for stains that might result from cuts in your skin. Thoroughly examine the top of your foot, the bottom of your foot, and the heel of your foot. Look for evidence of foot pressures or injury to the skin, such as callus, redness, blisters, or openings in the skin. Check each toe completely. Look for thickened, ingrown, or long nails. Nails such as these should be trimmed by a medical professional. Be sure to look between and in the creases of each toe. Moist white tissue resulting from toes pressing together is a common cause of ulceration. If you can't see clearly, use a mirror or ask someone else to help you. The next step in self-inspection is to check the temperature of your feet. Using a sensitive part of your hand or forearm, check each of your feet for hot spots, or ask a spouse or a friend to check your feet. Hot spots may result from local high pressures or poor-fitting shoes. If hot spots on the foot are found at night, check your feet again the next morning. Hot spots that persist into the next day indicate a pressure problem requiring immediate attention.
I'm feeling hot here, you know.
This side of the forefoot is a little bit warmer.
Mm.
If it's this warm tomorrow morning,
Yeah.
let me know or let your doctor know.
Okay.
Now check your feet for deep tenderness. Press each of these areas indicated by the red circles. Local tenderness may indicate an area that has been injured by high pressure and is very vulnerable to further damage. A combination of tenderness, swelling, redness, and warmth may indicate an infection or bone injury and requires immediate medical attention. This foot is an example of an advanced case with complications. With proper foot care, this should never happen to you. The last technique is shoe inspection. Before putting your shoes on, smooth out any wrinkles in your socks. Never wear socks that have holes in them, as they may cause blisters. Check the inside of your shoes for protruding nails, ridges, or foreign objects. Look for worn areas in the lining of the shoe. Carefully inspect the insole for evidence of excessive wear. If the shoe has a removable insole, make sure it is always fitting in its proper position. Now check the outside of the shoe for undue or uneven wear. Look for stretching out of the shoe and rounding of the edges of the heel and sole. Badly worn shoes will cause uneven foot pressures. Evidence of excessive insole or shoe wear should be brought to the attention of your shoemaker, therapist, or doctor. We have just shown you a way of protecting your feet from injury through daily self-inspection. Remember, look for evidence of pressure, such as callus, redness, blisters, or open areas in the skin. Feel for local areas of increased temperature. Press these areas of your foot for deep tenderness. And check your shoes and insoles for undue or uneven wear. But most important, report signs of foot injury to your medical professionals and have worn shoes and insoles repaired or replaced.
Well, since I have insensitive feet, my best advice to the patients with the same problem, from my own experience, the very first thing in the morning that I do is check my shoes to see if there is any strange matter or something like that inside the shoes. And then check your feet every day to see if you see anything wrong, like a little sore, redness, any something that you think is, you could check and later have it checked by your doctor or something, because, sometimes that's where with a little problem, a big problem starts right there.
This program was developed by the Physical Therapy Department, Rehabilitation Branch. Produced by the Training Branch, National Hansen's Disease Center, Carville, Louisiana. This woman's normal skin may never really need the special care she gives it, but in Hansen's disease or diabetes, nerve damage may cause a loss of sensation in your feet, causing your skin not to sweat, not to produce its natural protective oils, creating dry, cracked skin, increasing the possibility of an open wound. Your Feet Skin Care, a patient guide to the proper techniques of moisturizing, nail trimming, callus, and wound care, problem prevention, and the absence of a pain warning system.
When we have no sensation in our feet, the skin dries up, and it gives you a lot of trouble. You can get ulcers around your ankles or something like that due to the fact that they bump them against something, and you'll have a little blister, and the first thing you know, it turns into an ulcer. But if you keep it soft like that, it's not that easy when you bump into anything for it to open up on you or have a sore that way.
There are several ways of replacing moisture in dry skin. The ideal method is to soak the feet for 20 minutes in lukewarm water every day. Do not dry your feet after soaking. Shake off excess water and immediately apply mineral oil or Vaseline. The oil should be massaged into all surfaces of the feet except between the toes, where excessive moisture is a common problem. Let's show you a more practical approach to moisturizing dry skin. After your daily bath or shower, apply oil to the skin using a squeeze bottle. As in the soaking method, the oil must be applied before drying off so that the water is trapped against the skin. Proper moisturizing techniques will prevent cracking of your skin due to dryness. The next technique in skin care is proper nail trimming. Toenails are a specialized form of skin and must be cared for on a regular basis to prevent ingrowing. The nails should be trimmed straight across approximately once a month. Rough edges should be smoothed with an emery board.
If your nails are extremely thick or deformed, as these are, a medical professional should assist you in their care. Callus reduction is another important technique in caring for the insensitive foot. Callus is a normal response to increased stress on the skin. Regular callus care is required to prevent excess buildup from producing additional pressures on the foot. The safest way to reduce callus thickness is to use a callus file or sandpaper. Cutting with knives or razors should be avoided. This could result in infection and injury to your foot. Sand or file callus when the foot is dry. Use slow strokes in one direction only to prevent skin injury. Never try to remove all the callus thickness at one time. Feel the skin with a sensitive part of your hand or forearm to check your results. The skin should feel soft after filing the callus. Despite your best efforts, occasionally you may injure your feet. You will now be shown how to care for open wounds. If openings in the skin occur, 2 important steps are necessary for healing. The wound must be kept clean, and the foot must be rested. Always wash your hands with soap and water before and after caring for wounds to prevent infection. Your small wounds should be also cleaned with soap and water and pat dry with clean gauze or towel. Peroxide may be applied directly to the opening to further clean the wound. Next, apply a topical antiseptic such as betadine. Finally, cover the area with a Band-Aid or light dressing. A bulky dressing in a shoe will cause pressure and further injure the wound site. Rest the wound by minimizing movement, and do not walk on your foot, especially if the opening is on the bottom. This prevents further injury and spread of infection into the foot and leg. Crutches or a walker may be used to remove all weight on the bottom of your foot. A plaster walking cast is another method of healing a wound on the bottom of the foot. The cast rests the foot and reduces pressure under the open area, but still allows the individual to walk. Ulcers such as this result from pressures during walking, and the only way that we're going to get this ulcer to heal is if you eliminate all your walking activities. Now, we could take the weight off the bottom of the foot by using crutches, or you could get into bed and keep the foot elevated and not walk on the foot, or we could put you into a cast, which would reduce the pressure on the bottom of the foot and still enable you to walk. But the only way it'll heal is by resting it and eliminating the walking pressures on the bottom of the foot. Immediately report large or deep wounds like this one to your medical professional, as well as small open areas that do not show signs of healing after a few days. We have just shown you a way to prevent problems with your feet through proper skin care techniques. Remember, moisturize dry feet by daily soaking and oiling. Carefully trim long nails straight across. File thick callus areas. Keep clean and rest open areas in the skin, and report large or slow healing wounds to your medical professional.
So it's up to you. You can either spare a few minutes to protect yourself and ensure that you continue to function and earn your living, or you can neglect trivial injuries and end up by coming back to the hospital. So if you want to continue to function fairly normally, you have to care for yourselves.
This program was developed by the Physical Therapy Department, Rehabilitation Branch. Produced by the Training Branch. National Hansen's Disease Center, Carville, Louisiana. Shoes, like feet, come in a great variety of styles and shapes. A person with normal pain sensation can wear most shoe styles with little risk of injury. But in Hansen's disease or diabetes, pain sensation in your feet may be lost, and poorly designed or improperly fitting shoes may cause serious foot injury. Your Feet Footwear Selection, a patient guide to proper shoe style, fitting, wearing habits, and repair. Problem prevention in the absence of a pain warning system.
I know patients here that are given shoes, special shoes to wear, but at times they may wear them around for a while, then they turn around and want to wear nice looking shoes because they don't want to go out with these shoes, one thing or another, and they have problems with their feet. I've seen it here happen many a time. With me, I mean, the shoes that they make for me, I mean, they don't look as good as one of these fancy shoes or nothing like that, but they're comfortable for me and they help my feet, which I know now that that's what I need. It's more important for me to wear the correct shoes and to wear the other shoes.
Let's begin by demonstrating the proper style and fit of a shoe. The shoe should fit the shape of the foot. The uppers should be made of leather. Leather stretches and over time will mold to the shape of the foot. Lace or strap closures provide adjustment to minimize heel slippage. The heel should be of moderate height. A wedge-type sole is preferred, since this design is more stable than the standard shoe. A standard shoe such as this one will bend in the middle, allowing greater foot movement, which will result in increased stress on the foot. This wedge-soled shoe will not bend in the middle, thus providing a stable platform for walking. Lastly, crepe soling provides about twice as much softness under the foot as leather. A shoe of the correct length should bend at the ball of the foot. In addition, there should be at least 1/2 inch between the longest toe and the end of the shoe. The toe of the shoe should be as wide and slightly higher than the forefoot. The shoe should be snug but not tight. A properly fitted shoe will fold slightly when the leather on top is smoothed with the thumb. Some footwear styles should not be worn if your feet are insensitive. Thongs can cause blistering between the toes. Narrow-toed shoes will cause excessive pressure on the sides of the foot. Plastic uppers will also cause foot pressure because the material will not stretch. High-heeled shoes will cause increased stress on the ball of the foot.
Hi, how are you today? Let's take a look at the shoes you're wearing. These are not the best shoes for your feet. These shoes are both too narrow, and the heel is too high. They'll end up causing problems on the sides of your foot and the ball of your foot. I see you brought another pair of shoes with you today. Let's take a look at your jogging shoes. Why don't you try these on and I'll check the fit. These shoes fit much better. They're both wider, heel is lower, and they're deep enough that we can put a soft insole inside. This is the type of shoe that you should wear every day in order to protect your feet.
If it helped my feet, I'd try it.
Most individuals can be fitted with an ordinary shoe. But if your feet are insensitive, a special insole may be needed for protection. Remember to allow extra room in the shoe for the insole. If you do not, the shoe will be too tight, such as this one. An extra depth shoe will allow room for an insole when fitted with your normal shoe size. This is the preferred type of shoe. If your shoe was designed to be worn with an insole, do not remove it. This could result in injury to your foot. In some cases, an irregular shaped foot may require a custom shoe. A person who has had a foot ulcer in the past may also require a special sole called a rigid rocker. The rocker sole is designed to decrease the pressure under the ball of the foot during walking. Your activities of daily living must be adjusted to meet the special needs of the insensitive foot. In order to protect your feet, you must never go barefoot. Walking in socks or on carpeting does not offer adequate protection either. A pair of soft molded sandals should be kept near your bed. If it is necessary to get up at night, put on your sandals first. When showering, wear a pair of water-resistant sandals to protect your feet. You should have at least 2 pairs of well-fitting sandals or shoes. Wear each pair on alternate days. This will provide different weight-bearing patterns and prolong the life of the footwear. Never walk long distances without a rest. This will minimize the possibility of injury to your feet. Avoid running or jogging, as this activity greatly increases the stress on your feet. New shoes should always be broken in slowly. In general, do not wear them more than 2 hours a day for the first week. Afterwards, change into an older pair of shoes or sandals. Inspect your feet very carefully during the shoe break-in period. If a problem occurs, do not wear your shoes or sandals until they are checked by your doctor or therapist. New shoes may require adjustments to ensure a proper fit. A shoe shop can make the necessary adjustments. Footwear will need to be repaired or replaced periodically. Worn soles and heels can be repaired. Insoles must be replaced every 6 months to 1 year in order to remain effective. Torn linings or badly distorted uppers require shoe replacement. We have just shown you some methods of protecting your feet from injury through proper footwear selection. Remember, select shoes that fit the shape of your foot. Protect insensitive feet by never walking barefoot. Break in new shoes slowly. Repair or replace worn insoles, shoes, or sandals. But most important, report any problems to your medical professional.
That footwear is not to be used until the sole drops off. It lasts about 6 months or so, and you have to go back to the orthotist, and he renews the inner sole. It doesn't last forever.
This program was developed by the Physical Therapy Department, Rehabilitation Branch. Produced by the Training Branch, National Hansen's Disease Center, Carville, Louisiana.